Okay guys, so this is the second half, and just to recap really quickly, if it's been a while since you watched the first video, we left off at enteral feeding, which is tube feeding. I had briefly mentioned about bottle feeding puppies or kittens, so there's a video for you to watch on that. And then of course we have minimally invasive, relatively easy tubes like the nasogastric or nasoesophageal. And then we have tubes that are a little more in depth or a little more critical, I guess you'd say, like the oops, where do I click go? The esophageal tube, there it is, and then of course the PEG tube, that percutaneous endoscopic gastrotomy tube. How do they come up with these names? So just to check your notes, when you're dealing with nasoesophageal tubes, you can just place those with a little bit of sedation and freezing, and then they can stay in easily for a few days in hospital. We don't usually send them home. They're usually smaller tubes, so not as big around. They're very, very tiny. So we have to put down liquids only. It's really, really hard to meet their calorie requirements just because you have to water the food down so much to get it through that tube. With the other two, the esophageal and the PEG tube, you have larger bore tubes. So you're better able to get some of the chunkier foods down. You don't have to water them down as much and run them through the blender as much. So it's a little easier to meet the calorie requirements if you're using those two tubes. But they both require general anesthesia to place. And in the case of the PEG tube, you have to have an endoscope. So if you're at a practice that doesn't have an endoscope, you're not placing PEG tubes. But you can easily place an esophageal feeding tube if you've got the right type. Before I move into parenteral feeding, which is the bulk of this particular video, one more tube to mention. It is very rarely done, but there are some specific situations, and that's the orogastric tube. So let me get my picture out of the way. And this is a large bore tube. You can see how big it is. We'll use usually a roll of tape. So this is actually a roll of bandage tape that you place between the animal's jaws. This animal might be sedated. They are not likely under anesthesia. They may even be fairly awake, but fairly sick. So this is an orogastric tube. It's going in through the oral cavity and it's going all the way down into the stomach. And this can be used for a few different things. It is a very short term. You put it in, you do what you need to do, and then you pull it out. So in this case, they are going to lavage the stomach. This patient has ingested something, probably a toxin that is caustic, and they need to actually wash the stomach and get all of it out so it doesn't cause any irritation and possibly perforation of the stomach. The other times that it's been used is if you have an animal who has food bloat and you have to get those stomach contents out. Sometimes those are placed intra-op, so while the animal is under anesthesia in surgery, you'll place or run a big stomach tube like this. And these ones are, again, a much bigger bore. You're generally not, unless you're doing a lavage, you're not using this for feeding. This is, the only reason I mention it is that it's another type of tube that goes into the stomach. But again, you're not doing this for feeding. You can imagine this would be stressful. There's dangers in getting bit or harmed, and it's definitely not a pleasant experience for the dog. So these are done usually in emergency situations, and it's not one that you see very frequently at all. Okay, so let's get into parenteral feeding. And I'm going to come back. Ta-da! And this is what the parenteral nutrition bags look like. And you can see on this one here, it says store between 2 and 8 degrees Celsius. So quite often these need to be refrigerated. They have a combination of carbohydrates, protein, fats, electrolytes, and they have dextrose in them. Anything with OSE is a sugar. So dextrose, sucrose, fructose, glucose, those are all sugars. Dextrose is what's in these. If it is a total parenteral nutrition, so it's replacing all their nutrition, they do not need to eat anything on their own. That's when we would use total parenteral nutrition. So if we don't want them eating anything, maybe they've got an injury or some sort of defect or swelling or inflammation or something going on with their upper tract, with the oral pharynx, then we would use total parenteral nutrition. That doesn't require them to eat anything. They are getting all that they need through that bag and through that IV. If they are able to eat on their own, but we need to supplement for some reason, then we will use partial parenteral nutrition. So that's why we have TPN and PPN. And PPN also has some of those nutrients in there and electrolytes, as most fluids do, but PPN has less calories, usually because it's a much lower amount of dextrose. So total parenteral nutrition is usually at least 10% dextrose. Partial parenteral nutrition is generally less than 10% dextrose. So you're not going to be able to meet the caloric requirement with PPN the way you would with TPN. So that animal does need to eat a bit on their own, otherwise you'd have to switch over to the other type. Now the other problem is, with the total parenteral nutrition, notice that it is white. It's not clear at all, it's completely opaque. And that's also because it's got some lipids in it. And those lipids add to that milkiness. It also means that it's very irritating to give through a catheter. So you can't use a regular peripheral IV catheter like we would use for fluids. With total parenteral nutrition, it has to go through a central venous catheter or a central line. So these are usually, in our patients, a jugular catheter, and then it's got multiple lumens quite often in it. And you can put the TPN in through that. And they would run through a fluid pump just like we would regular fluids, which we're going to learn about next week. As far as the PPN goes, that you can run through a traditional catheter that would run into the leg. So it can go through a cephalic catheter, it can go through a saphenous catheter. It's still pretty finicky. You want to make sure you're using a dedicated catheter for it. So don't be switching between PPN and IV fluids. You would have, if you're running PPN to partially feed this patient, you would have one catheter for the PPN and one catheter for the fluids. So this patient would then have 2 IV catheters in. That means it's really important that if you're dealing or nursing with these patients or touching them at all, you need to make sure you're protecting those catheters. Because as soon as you lose one, if it blows, if it comes out, if it slips, you're toast. You now have fewer options for replacing that catheter because you can't go to the other leg. When it comes to the care and the monitoring, if a patient is at the stage where they are requiring PPN or TPN, they are critically ill. They are very, very ill. I have only ever encountered PPN, and that was in emergency practice. I have not worked in specialty practices, so I don't have any experience with TPN, and I think that's probably rarely done as well. But you would have to talk to a specialist to get that better idea of how often they actually use that. However, remember I said that these solutions have electrolytes and dextrose and some nutrients in them, which it feeds our patients. It also feeds bacteria. So I'm going to get out of the way. Bye-bye. And then these, I apologize, the quality of these pictures are not great. They are the best I could find. So what we've got is a close-up of the IV bag. And this is an IV port that spikes into the bag, so it punctures the bag, and that way we can administer the fluid, comes down through the drip chamber and into the line. So whenever we're handling this, these people, we need to have gloves on. What they also do, and it's hard to see, but this is a small bandage with iodine, a little piece of gauze that they put over where this spike goes into the port. So they put a little piece of iodine on there as a disinfectant, and then they're going to wrap and tape that up to keep that as sterile as possible. These need to be handled with strict aseptic technique. Doesn't matter if it's TPN or PPN. You need to be very aseptic and avoid contaminating any parts where the line joins, like here. That's not blood, that's iodine they've put on there. Then they tape it up, and of course they've got the same on the port on the bag. So you have to make sure that you're not getting any bacteria, any contamination, anything into this line, because of course the bacteria will actually breed in the line and they'll reproduce in the bag, and then you're basically flushing bacteria and infection into your patient, which is just going to make them sicker. If you are wearing gloves and you are touching them, then you have to switch your gloves the very next time. So you're not going to be reusing gloves on this. If you are unsure about anything and you're encountering it, if you see a fluid bag that's hung that is not clear, colorless, don't touch it, ask. A lot of times, I'm going to go back a slide for a second, and a lot of times these bags have to be protected from light. So it's not uncommon to see a bag like this that is protected from light, covered with a paper bag, wrapped in vet wrap or foil, just to make sure that the nutrients that are in the bag don't break down. Some of the nutrients will actually break down when exposed to light. So they often have to be protected and they have to be covered up. Either way, make sure you maintain an aseptic technique. Keep it sterile. Wear gloves, wipe the ports and hubs. So if we're not injecting into this line at all, we're not putting anything through this line except the TPN or the PPN. We will never use both at the same time. It will be one or the other. Because of course, if you're doing complete nutritional replacement with the total parental nutrition, you don't need the partial one. And if you're using the partial one, you know they need to eat. So even if they're on it, do make sure you start offering them food. If they're able to eat, they need to, because ideally you want to get them off that total parental nutrition. So a little bit repetitive, but if you ever encounter this, it's something really important because these animals are critical. You have to watch the lines, you have to protect their IVs. These patients, of course, will be wearing e-collars so that even if they do start to perk up and they want to get at their line or their port, they're prevented from doing so. And that's it. I'm not going to go any further deeper into this, partly because I don't think it's very often you're going to encounter it. The other thing about it is that there are videos on DC Connect for the tube feeding and everything. So I'm going to keep it really simple, and your total lecture ends up being less than 30 minutes. So quick reminder of some of our goals. Looking at the various types of feeding tubes, the drawbacks and benefits of each. Obviously the benefit is we get to feed them, and some of them can be nice and easy to place, but maybe shorter term, and then others more difficult to place, but much longer term, more flexibility on what we can put in there. And then the total parenteral and partial parenteral nutrition, those handling and considerations of those, and what we need to keep in mind when we're dealing with those. As far as your homework goes, really simple. I want you to go through some of your nutrition notes and your resources. Make sure you know how to calculate caloric requirements. It is something I'll be looking for you to do in your case study that's going to come out next week. Ta-da! And then, of course, get familiar, look at some of the resources, the links you might have had in your nutrition course, and look for recovery diets, look for critical care diets like the liquid diets. I think Clinicare RF is one. I think Royal Canin makes some liquid diets. I know Hills has the AD canned food that can very easily be pulverized or pureed with a bit of water. And then there's also one for syringe feeding rabbits. You can do nasal tubes, nasogastric tubes on rabbits, and you can feed them critical care for herbivores, which, believe it or not, if you want to syringe feed them instead, comes in an apple and banana flavor. So lots of options that way. And then, of course, the videos that I've mentioned time and again, so I've got those. I will also be posting a reading guide and some pages from the Sirois textbook for you to go through. They do get pretty deep and pretty technical. So again, as with some of the other readings, keep an eye on the goals and on what I want you to know versus getting too deep and bogged down in some of the math and the equations and everything else. The main thing I want you to know when it comes to math is how to calculate calorie requirements for a patient, just to make sure that they're eating enough per day. Other than that, if you've got any questions, as always, use the questions for the prof area on DC Connect. Hopefully this is short enough. And if you've got any questions about the case study, we'll address those when it releases next week.